Welcome to our live webinar titled Aplastic Anemia and Hypoplastic MDS, a Diagnostic and Treatment Dilemma. Thank you for joining us. My name is Lee Clark, patient educator, and I will be moderating the presentation today. As we get started, we recognize the generous support of Bristol Myers Squibb, Jazz Pharmaceuticals, Agios, Genentech, Takeda Oncology, and the generous support of our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all the questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Tiffany Tanaka, who is a board-certified hematologist specializing in the diagnosis and treatment of blood cancers and blood disorders. She completed a fellowship in hematology and oncology at UC San Diego School of Medicine, where she also completed a residency in internal medicine. She earned her medical degree from John A. Burns School of Medicine at the University of Hawaii. Dr. Tanaka is a member of the American Society of Hematology, where she has presented her research work. Thank you, Dr. Tanaka, for joining us today.
Thank you so much, Lee. It's a pleasure to be here, and I'm really grateful for this opportunity. The topic that we will be discussing today is aplastic anemia and hypoplastic myelodysplastic syndromes. These are 2 different disorders with a lot of overlap, and therefore it's been quite difficult to diagnose and treat these 2 different disorders. And so we'll be talking about some of the potential differences. Next slide. Before we dive into what the actual disease states are, I wanted to briefly go over what normal hematopoiesis is, or normal blood cell production. Up at the top, you'll see a blood stem cell. This is what we call a pluripotent stem cell, or the ability to generate virtually any blood cell that we see in circulation. If you could click next, that red box is highlighting the myeloid side, or the myeloid cells that are derived from the stem cell. These are the cells that are affected in disorders such as myelodysplastic syndromes and aplastic anemia. You'll see that the blood cells towards the bottom are the cells that are actually detected when you do a blood draw from the arm. Red blood cells, platelets, and several of the white blood cell subtypes. These are nicknamed the granulocytes. The reason why is because the cells have a lot of granules within them. These contain important enzymes that help to kill bacteria and other functions. Next slide, please. So before jumping into the diagnostic dilemma between aplastic anemia and hypoplastic MDS, I wanted to review the, I guess what we would call a more typical MDS pathophysiology. So this is a little diagram that I created. Up at top, you'll see bone marrow versus blood. The bone marrow is found within most of the bones of our body, and that's where blood cells are formed. When they are fully mature, they are then supposed to be released into the circulation. Next. In disorders of of the bone marrow. One of them is called a precursor disorder, nicknamed CHIP, or clonal hematopoiesis of indeterminate potential. These patients will develop a mutation that may actually be silent. The blood cells may even appear normal and be of normal quantity. And this tends to happen with age. Next, please. If that initial mutated blood cell, such as the blue cell that acquired a DNMT3A mutation, that cell is a little bit more vulnerable to other mutations, such as this RUNX1 pictured. Next, please. And so other mutations may also be born, such as this green cell with a different mutation. Next. And that's when we see diseases that are more full-blown or actually apparent in the bone marrow. What happens in MDS is these mutations are acquired. These mutations are not things that people are born with, but things they pick up along the way. And these mutations give the blood cells a growth advantage over the normal healthy blood cells. And so what we see is this paradoxical effect where the bone marrow makes too many blood cells, but these blood cells are not healthy and they don't mature properly. And as a result, the circulation is much less populated. And that's where we see low blood counts. What can happen to a small subset of MDS patients, sadly, is more mutations are picked up, such as this NRAS mutation. Next. And the NRAS is what we call a pro-proliferative mutation, meaning that it makes the blood cells multiply much too much. And so something like acute myeloid leukemia can occur. Next slide. So before we get into the dilemma between overlap syndromes, I wanted to talk about how we diagnose MDS, as perhaps this is a little bit more straightforward. Next. When patients are referred to the clinic for suspected MDS or other bone marrow syndromes, our first step as a hematologist is to rule out or to test for things that are not bone marrow disorders. These are things that fortunately are often reversible or perhaps could even be cured. So a lot of times the patient's history or their medical background will give us clues to this. For example, a really common culprit is vitamin deficiencies, say in a patient with prior bariatric surgery or gastrointestinal issues. Other common causes that we often see are people with other organ damage, such as kidney disease, where these other organs are responsible for making growth factors. In the case of the kidney, the kidneys make something called erythropoietin that tells the bone marrow to make more cells. So that's our first step as a hematologist. We rule against all the other causes other than the bone marrow. Now, if those things are pretty confidently ruled out, we have a long list of possibilities, as you can see, and a bone marrow biopsy is often the next step. This diagram on the right is illustrating the great amount of overlap we see between MDS and other syndromes. Up top is what we're going to focus on today, AA standing for Aplastic Anemia and h-MDS for Hypoplastic MDS. What's very difficult is sometimes there is overlap between these syndromes and it's hard to categorize patients into one box. But that being said, even if we can't put someone concisely into one category, sometimes the treatment approach is quite similar. And so we often think about what's driving this to choose what the treatment is, even if the diagnosis cannot be concisely made. Next slide. So how does MDS affect patients? Almost universally, patients will have low blood counts, and the result of this is a higher rate of bleeding, often due to low platelet count or thrombocytopenia, a higher rate of infection, which is due to a low neutrophil count, which is one of the white blood cell types, and also due to anemia, causing the need for transfusions and anemia-related symptoms such as fatigue. And as mentioned earlier, about 1/3 of patients with MDS will go on to develop acute myeloid leukemia, which very severely shortens the survival. Next. So that's how patients present to the clinic. How we actually diagnose is based on morphology. or what the pathologist sees under the microscope in regard to the blood cell shape and size. The things that are showed in these pictures are hallmarks of dysplastic cells or abnormally shaped cells. For example, the pseudo-Pilger anomaly shows a classic type of nucleus that's those two little bulgy things. They're supposed to be much more segmented than that. Another hallmark is the ring sideroblasts. You can see on the top right where there's a lot of these small dots around the nucleus. And another hallmark is the myeloblasts in the bottom right. Blasts are the most immature type of cell that is the culprit of leukemia. It turns out MDS patients can have blasts as well. And there's a distinct cutoff at 20% that defines MDS, where if you go over 20%, that is acute leukemia. Next. In addition to the abnormal morphology that the pathologist sees on the bone marrow and on in the blood, there's also the ability to test the chromosomes, or what's called cytogenetics. It turns out that half of patients with MDS will have chromosome abnormalities. These are structural changes that should not be present in normal individuals. What's pictured here is one of the classic subtypes of MDS. It's called deletion 5q, where chromosome number 5 has part of its arm missing. That's what the arrow is pointing to. Now, only half of patients will actually have a cytogenetic abnormality, and so it's not the best clue, as half of patients won't have this clue, and so we have to rely on other things. Next. That other tool is genetics. I was getting at that with the first slide where we looked at the evolution of MDS. Genetics is DNA mutations that are picked up with age. One thing that I reassure patients about often is the word genetic often implies that it's hereditary. But when we talk about genetics in MDS, most often it is mutations that are acquired as people get older. So in that sense, the one fortunate thing perhaps is that it's not passed on to the next generation, although it is an unfortunate event. Now, genetics have been very helpful for MDS, as the majority of patients, 80 to 90%, depending on what study you look at, 80 to 90% of MDS patients will actually have a genetic mutation. So in some eyes, it's a much better clue than cytogenetics, as the majority of patients will have these abnormalities. Next slide. And so in medicine, we love to subclassify things and try to figure out more precisely how patients are defined. And so the World Health Organization has done this for all blood disorders or blood cancers. And this is the current scheme for MDS. This is mostly based on the morphology and not so much on the cytogenetics or the genetics. Next. I believe, yeah, so I'm just reiterating here that the diagnosis of MDS is made by the presence of dysplasia or abnormal morphology. And the cutoff that is given is 10% or more of the bone marrow cells, and also that they have not crossed the boundary to leukemia at that 20% blast count. Next slide. So as mentioned earlier, morphology is the hallmark, but genetics are really helping us understand the disease better. This was one of the most pivotal trials on genetic discovery in MDS, made by my mentor, Dr. Behar. As you can see here, these are all the different gene mutations that he helped to define in MDS patients. The rows are the different mutations, and this, the thin vertical lines is an individual patient. The take home from this is that no two mutations or no two patients often will have the same profile. That's what makes it pretty hard to use mutations. Everybody will be quite different in MDS. Next. And then following Dr. Behar's study was one by Dr. Papa Emanuel. Similarly, she found a great degree of variety of mutations in MDS. Next. And soon after that was Dr. Haferlach. His study also found a great degree of genetic variation or heterogeneity, a big mixed bag of different mutation profiles. Next. So when we approach MDS patients, the biggest question we have perhaps is, how long will I live? And can you make me live longer with treatment? So MDS, most people will say, is a cancer. And in most cancers, we stage. Now, unlike solid tumors where we can use the standard stage 1 through stage 4 system, blood cancers are different. The stage 1 through stage 4 system often uses the degree that the cancer has spread or metastasized. And what makes blood cancers different is that the blood cancer is present already throughout the bone marrow. And so we use completely different staging systems. The one that we use most often for MDS is called the IPSS-R, or the International Prognostic Scoring System. As you can see in those 5 different colors, we have come up with 5 different categories, and those range from very good to very poor. Step 1 is basically looking at the chromosomes, or that cytogenetic structure. And based on what sort of chromosome abnormalities are present, you can classify a patient into very good to very poor. Step 2 is then calculating the actual risk. So this not only uses the cytogenetics or the chromosomes, but also the percentage of bone marrow blasts and how low the blood counts actually are, the hemoglobin, the platelets, and the neutrophil count. So once you've tallied up your score, that's step 3. You use the score to figure out which category or risk group the patient is in, very low to very high. So on that bottom table, you will see what score is assigned to each category. And perhaps most importantly, what is the median survival? So for example, a very low patient there, the median survival is 8.8 years. Now, median means half of patients will do better, half of patients will do worse. So I always remind patients of that too. And then very high risk MDS, unfortunately, is a really limited survival. Median there is 0.8 years. Next. And so this is the survival plotted out on a graph. And so survival is on the bottom, and then percentage of patients is shown vertically. Very low risk, again, is that blue line, and very high risk is the red line. And so you can see that the percentage of patients living for years is much lower for that very high risk red line. Next. Similar to survival, the rate of leukemia transformation is much higher in very high risk patients. Next. And one thing, again, I really wanted to bring home is that half of patients will have a normal chromosome structure. This is going to come back when we talk about aplastic anemia. And so chromosomes just really aren't the full story. If half of patients are normal, yet they have high-risk disease, we know that there's other indicators that explain the disease better than chromosomes do. Next slide. So this is what has been so far discovered that we can rely on for genetic mutations. Very long list. It's put in order of how frequent the gene mutations come up. Now, what's not clear is how to incorporate these different gene mutations into that score that we just looked at. And the reason why is there's just so many mutations and so many mutation combinations. And so this is still very actively debated at our hematology conferences. Next. And so perhaps the take home for gene mutations at this point is that it can certainly help bring home the diagnosis of MDS, and maybe it also helps predict survival. But we're not formally incorporating it yet, although some experts are definitely relying on mutations to make decisions. Next slide. So now that we've laid the groundwork for MDS biology, I wanted to now talk about hypoplastic MDS versus aplastic anemia. In my eyes, 2 disorders that perhaps are a little bit more difficult to diagnose, and sometimes there is just a tremendous amount of overlap between these 2 syndromes. So the bone marrow, as as mentioned earlier, is where normal blood cells are produced, as well as malignant blood cells. What's shown here is the inside of a bone, which has that spongy matter, and the hematopoietic or blood cells are generated there. Next. A bone marrow biopsy is how we actually get a sample, and we do this in the iliac crest, or the back of the hip bone. We do it there because it's a very large bone. Unfortunately, it's not near a lot of vital organs. And also we can actually feel the bone, and it makes it at times feasible to do at the bedside. Next slide. And I wanted to review the bone marrow architecture, because this is how we really rely on making our diagnoses. And so normal bone marrow is actually going to decrease its production as people age. And so what's shown here in this first picture is all the blood cells in the pink to dark purple. And then the large white circle is actually fat tissue, or adipose. And so as people get older, they actually increase the amount of fat tissue, and the amount of those purple pink cells decreases. The way we roughly calculate the normal amount of cells that's expected is subtracting the age of the person from 100%. So for example, a 60-year-old patient should have about 40% cellularity in the bone marrow, meaning 100% minus age 60 equals 40. Next. With hypoplastic MDS, the cellularity is thought to be less than 20 to 30%. There's a caveat there, because an 80-year-old patient would have a cellularity of 20%. So what we often say is the cellularity should be less than expected for the age. Hypoplastic MDS is seen in a minority of MDS patients. Most studies will quote 15 to 20%. As the majority of MDS patients will actually have a hypercellular marrow, or too many blood cells. And most studies will say that hypoplastic MDS is more often seen in women. Next. Aplastic anemia is similar to hypoplastic MDS, where the bone marrow just appears quite empty. To make this diagnosis, you have to exclude MDS and AML, but that can be quite hard. As you can see from these two pictures, the morphology looks quite similar. There's an empty bone marrow with a lot of adipose tissue. Next. So hypoplastic MDS we'll focus on first. To understand how to treat it, it took a lot of discovery on figuring out how this disease even comes to occur. Most people settle on thinking that hypoplastic MDS is an immune system problem. It's thought that perhaps the immune cells are much too active, and the immune cells actually trigger a reaction against the stem cells, destroying them and not allowing the bone marrow to make enough healthy cells. There's even further speculation that the MDS cells make bad proteins, cancerous proteins, that actually activate the immune cells and cause them to behave abnormally. What's been studied over and over again is a very tight correlation between hypoplastic MDS and autoimmune disorders, such as rheumatoid arthritis. And most studies also say that MDS patients that are hypoplastic will do better than patients with typical or hypercellular MDS. But what's very difficult to make this diagnosis is, as we mentioned, morphology is the hallmark for MDS. But if you have a low amount of blood cells in the bone marrow, it's hard to evaluate that morphology. What's shown in these pictures here is up top is, again, a hypoplastic MDS patient with more than expected adipose or fat tissue. What's on the bottom is those brown cells are stained for something called CD34. CD34 is a protein expressed by the leukemia blasts. And so if you stain for these blasts, then you feel pretty confident that the MDS process is there. And so that's another way to get around the limited sample that might be present. And so rather than relying purely on the morphology or the shape abnormalities, there are other tools that our pathologists use, such as the stain. Next slide. So before jumping into hypoplastic MDS treatment, I wanted to go over classic typical MDS treatment. Next slide, please. And to understand treatment, we're going to go back to that risk score next. And so with all cancers, the way we approach treatment is to know how severe the disease is, so we can determine how intense the treatment needs to be. So just to review here again, very low versus very high, there's a very clear survival difference. Next. With very low patients being defined most often as very low or low risk. I'm sorry, that was for lower risk disease. And in the blue here, that blue arrow, again, the survival for a low risk patient is on the order of several years, 5.3 in this study. And so for these patients, their survival is not immediately limited. Often the disease is not as severe and the blood counts are not terribly low and can be adequately supported by perhaps low intensity treatment such as transfusions or growth factors such as erythropoiesis stimulating agents, drugs that actually tell the bone marrow to make more red blood cells. There are two different drugs that are relatively new. One much more new, luspatercept, that I'll review on the next slide. But these are both drugs that are low intensity and not too difficult for most patients. Next. On the contrary, higher risk MDS is defined by patients with intermediate, high, or very high risk disease. And as mentioned earlier, the disease tends to limit survival quite a bit. For intermediate risk, median survival 3 years, for very high, 0.8 years. And so treatment is more intense. Hypomethylating agents are thought to be low intensity, but still more cumbersome than supportive treatments. And lastly, the only cure for this disease is a stem cell transplant. Next slide. And so as mentioned, these two drugs for lower risk MDS are very specific to the type of MDS. For lenalidomide, it's for patients with that deletion 5q. And it actually is quite good for those patients. The majority of patients no longer need transfusions on this drug. Luspatercept is the newest kid on the block, recently approved by the Food and Drug Administration. And it's for patients with those ring sideroblasts. And the response rates weren't terribly high, but still beneficial to 40% of patients in the study, where 40% of patients were relieved of needing transfusions for greater than 8 weeks. Next. Now, as mentioned, for higher risk MDS patients, there are two different drugs in the same family. They're called the hypomethylating agents, or HMA, I'll say going forward since that's a long name. These are IV or subcutaneous drugs. The oral drug is on the way, but for these drugs, you actually have to go to your local cancer center 5 to 7 days in a row and get the treatment. Now, what's probably my least favorite thing to tell patients is the benefit rate is quite low. Only 40 to 50% of patients will benefit. And if in that 50 to 60% of patients that do not benefit, their survival is quite low. Average here is 5.6 months. Next. And so this only cure for this disease is a transplant, but as can be imagined, it's quite an ordeal. And while the only shot of cure, we do see a lot of deaths along the way, either as complication or the transplant did not fully cure the disease. Next slide, please. A little bit more about HMA therapy, or the higher risk treatment. I mentioned that my least favorite thing to tell patients is that only half of patients will benefit. Maybe a close second to my least favorite thing to say is that the blood counts actually get worse before they get better. And so the beginning can be kind of rough, needing more transfusions than before. And then what's quite terrible is that it takes many months to see a response. And adding to that, sorry to be Debbie Downer, but adding to this is that we still don't have a biomarker or a way to predict who's going to benefit. And so this is where a lot of research is being made to try to figure out, how does this drug work? Is it purely cytotoxic, meaning does it just kill the cells? Is it epigenetic? Does it change the structure of the cells? or is it changing the immune system? Next slide, please. And so I wanted to give a few examples of patients from my clinic. No names here, but just the blood count trends. This is a gentleman that did very well on his HMA. He was on decitabine and still is. The 3 different blood counts are shown here: white blood cells, hemoglobin, and platelet. The green and the blue lines are showing the normal range, and the purple line is him, the patient. And so what you can see is there's a lot of up and down with each cycle of chemo or each cycle of treatment. But the up and down, at least for some of the blood cells, was not fluctuating quite as much. And perhaps the best benefit to him was the hemoglobin, where in that middle graph, you can see he started at quite a low point, way below the normal green line. But after a few cycles, he came up, and he's at a level now of about 11 to 12, which is quite good, far away from needing a transfusion. Next, please. Now, here I'm showing an HMA non-responder. This is a patient who was dependent on transfusions, had low blood counts almost across the board. And you can see that his fluctuations did not lead to an eventual incline. And so he remained transfusion dependent and unfortunately did quite poorly. Next slide. Now here's another example of a woman that got azacitidine or HMA, and it did quite well for her. I don't have a lot of data because she got treated somewhere else and then came back to us for for her bone marrow transplant. And so she got 3 cycles of this drug. The HSCT is her hematopoietic stem cell transplant. And you can see, as expected, after the transplant, the cells went down a bit. She eventually recovered. But sadly, in red is SAML, secondary AML, where despite the transplant, her disease came roaring back and she succumbed to that. Next. And so this is her mutations. We were talking about these earlier. These were the mutations that helped to aid the diagnosis of her MDS that were identified before any treatment was given. Next. And then after treatment was given, we could no longer find those mutations. Yet the disease still came back with leukemia. So there are areas where we really could use the research to figure out, why does someone like this relapse so terribly despite getting the most intense treatment available? Next slide. And so when we approach MDS, there's a lot of different mechanisms that we know are involved, a lot of different cancer pathways that are not operating well. Next. And there are a lot of strategies, both precision and non-precision, that are trying to target these aberrant or abnormal cancer pathways that have just gone berserk. These are a lot of agents shown here that are in clinical trial testing. And what I want to do now is turn to hypoplastic MDS and talk about how these treatments may or may not be applicable to hypoplastic MDS. Next slide. So with hypoplastic MDS, we think there's a much more immune mediated mechanism, where with typical MDS or hypercellular MDS, maybe that's not the predominant thing. And so a lot of the treatment centers around suppressing the immune system. What I'm showing here are perhaps the 3 most commonly reported drugs: ATG, cyclosporin, and alemtuzumab. ATG is commonly given with cyclosporin, and the studies are quite small. Most experts in the field will say we actually underutilize this treatment. And perhaps the reason why is hypoplastic MDS is not in its own category. Some people feel it should be classified separately from MDS, knowing that the immune mechanism is perhaps what makes it unique. And so all that traditional treatment I showed you just before this, hypomethylating agent therapy, sometimes hypoplastic MDS patients are lumped into this. And so that could explain why our rates of response are quite dismal. Maybe a different approach should be needed. What I liked about this picture shown here from this publication is it gives an idea of how to tell patients what we might expect. Now, the case series and studies of these different regimens are limited to quite small numbers of patients. But perhaps a safe quote to say is roughly about half of patients with ATG and cyclosporin might benefit. And so when I say benefit, I mean a sustained full recovery shown on that top graph, where the patient, after months of treatment, will see their blood counts go up and no longer need a transfusion. Kind of like the hypomethylating agent therapy, patients who do not respond, half or more, will see a fall in the blood counts. And that could be at different rates and depending on how strong the disease comes back. And so that's the area of greatest need, what to do after the first line doesn't work. There's been many studies trying to figure out what predicts who will respond to this immune-mediated approach. And perhaps some of the strongest predictors is the gender, so female sex. Females tend to respond better. Younger patients, not too surprising, that's almost uniformly the case. And then certain genetic differences, specifically in HLA DR15, highly conferred with autoimmune disorders, and then trisomy 8, or an extra 8 chromosome. And then lastly, MDS that has not arisen from something else, basically MDS that came on its own. Next, please. Okay, so we covered hypoplastic MDS. Now I'll take the last 10 minutes or so to contrast it with severe aplastic anemia. So very similar to hypoplastic MDS, an aplastic anemia is also thought to be due to an overactive immune system that similarly attacks the hematopoietic stem cells and does not allow them to fully mature to the other blood cells. Many demographic studies have proven that it's actually a disorder more common in Asians, 2 to 3 times more, pretty equal between males and females. And now what's sort of a controversial area is whether to call this a pre-malignancy or a malignancy. Fortunately, it's the minority, but nonetheless, 10 to 20% of patients with aplastic anemia go on to develop MDS or even acute myeloid leukemia, unfortunately. And what's shown here again in that picture is to remind you of what the morphology looks like. It's mostly an empty bone marrow with very little of those purple-pink blood cells shown. Next slide. So with approaching this diagnosis, first and foremost is excluding other causes. So in that very first slide I showed with all the non-bone marrow disorders, it's crossing off things like other organs being involved. It's crossing off nutritional problems, HIV, hepatitis, that sort of thing. What's probably more difficult to exclude is cancer. So excluding MDS or leukemia. And I say it's difficult because there are so little blood cells to evaluate. And so sometimes the pathologist is not able to confidently say no dysplasia was seen. Maybe what's more easy to do is say there are no blasts seen. And so that's something often I notice that our pathology team will rely on. Once you have made the diagnosis, meaning you've excluded other causes and you feel pretty settled on aplastic anemia as the diagnosis, the next thing to do is categorize the severity. And so this is still a little bit up for debate, but most will say a non-severe aplastic anemia patient is one with more cells in the bone marrow versus a severe aplastic anemia patient has less cellularity and very low blood counts, a neutrophil count less than 500, a platelet count less than 20,000, and a low reticulocyte count, or the low amount of the very young red blood cells that are usually increased when patients are anemic. And lastly, there's a third category, very severe, which is meeting all the criteria for severe, but having an even lower neutrophil count of less than 200. So after you've diagnosed the disease, you've said how severe it is, next is figuring out which treatment, and that is largely based on the patient's age. Next slide. And so perhaps the biggest triage point is whether the patient has a sibling that could offer a bone marrow donor. And I say this because if a patient doesn't have a sibling, The other source of bone marrow from a non-matched donor, we know that patients just don't do quite as well. And so if there is a sibling available, then the next consideration is the patient's age. Less than 40, it's quite a stringent cutoff, but if you're less than 40, a sibling bone marrow transplant is usually the next step. The reason why the age cutoff is generally so strict, 40 is not that old, but there have been many studies that have shown that the older the patient is, the less well they do with the transplant. The transplant cells do not engraft as well. They do not they are not utilized by the recipient as well. And then there's also a higher rate of what's called graft versus host disease. Okay, so if a transplant is not explored, we're going to the more right columns, then an immunosuppressive approach is used, or drugs that calm the immune system. Next. And I just wanted to show a little bit of data on how patients do by their age. And so as mentioned, that cutoff of age 40 is often used. As you can see, that bottom line is the patient cohort that was greater than age 40. Their long-term survival was about 55%, whereas if you look at the patients that were 20 or younger, their long-term survival was 86%. And so there's definitely an age-related prediction. Next. Lastly, I wanted to show some data on immunosuppressive treatment for severe aplastic anemia. And again, another age-related effect is seen where patients who are 20 or younger have an 82% long-term survival versus above age 40, more in the order of 58%. Next slide. So trying to distinguish between the two disorders, hypoplastic MDS is perhaps more prevalent in females, whereas aplastic anemia, there is an equivalence in the genders. Hypoplastic MDS, the bone marrow will show the hallmark dysplastic changes, potentially ring sideroblasts, potentially blasts, and even scarring or fibrosis of the marrow. Where in aplastic anemia, you should not see any of those hallmarks of MDS. In regards to blood counts, hypoplastic MDS might not have all of the lineages or cell families affected, where in aplastic anemia, you are going to expect at least 2 cell lines are decreased. For the genetics, we do see less mutations compared to typical MDS, but nonetheless, a lot of the same gene families are affected. Whereas in aplastic anemia, there is really a lack of the typical MDS mutations. And I'll show one last graph about that. And lastly, perhaps most importantly, is the survival. So for hypoplastic MDS, most argue that people do better than typical MDS. And with aplastic anemia, maybe across the board, these patients live longer than both MDS and hypoplastic MDS. Next slide, please. And so this was a study that just came out that looked at survival. And as you can see, aplastic anemia patients did the best in terms of long-term survival. They're the top bar shown in green. Hypoplastic anemia was in the middle, and MDS was down below. The second graph on the bottom is the amount of leukemia transformation. And again, as expected, MDS patients did the worst. Hypoplastic MDS patients were underneath, and aplastic anemia patients fortunately had the lowest rate. Next. And lastly, just talking about mutations once more, MDS is shown in red. By the way, the authors, this was a fabulous paper, but they used different colors for different figures, and it tricked me initially. But now this time, MDS is shown in red. You can see there's a lot more ticks for mutations, whereas green is hypoplastic MDS. It's a lot less burden, a lot less mutations, but nonetheless, it's still present for a lot of patients. And for aplastic anemia, you can see there's really a low amount of mutations. So perhaps it's a good tool that can help us distinguish between all these disorders. Next slide. This is a review paper I wrote with Dr. Behar, where we are looking at all the different bone marrow disorders that potentially overlap with each other. And the argument is that mutations perhaps can help us figure out which category is the patient most aligned with. All the rows are different mutations. The columns are these different bone marrow disorders. And the different colors represent the frequency at which the mutations occur. Next. And so the take-home message is that gene mutations may certainly help supplement how we diagnose and distinguish these overlapping disorders from each other. Next slide. So lastly, this is my wrap-up slide. You can tell I've got quite leaning towards doing mutation testing. I'm a proponent of using it, but as a supplement to the classic bone marrow morphology. We're still not going to abandon that. We're going to use mutations to supplement it. As mentioned, there's a precursor diagnosis. Maybe the patient's not too severe, but we might be able to predict if there's something down the road for them. Next. We could refine the prognosis or the survival probability and help figure out who should go to an aggressive treatment like a transplant sooner. And lastly, it might tell us who's going to do poorly even despite a transplant. So I bring this up because that patient I showed you folks who did quite well with her treatments but still got leukemia, she's one where I think the type of mutation she had was highly predictive of this. Next slide. And this is my thank you slide. I just wanted to thank the Aplastic Anemia MDS International Foundation for this opportunity. It's been a pleasure working with them. Neil and Alice have been wonderful. Neil has the same Hawaii roots as me, so I'm showing here a picture of Waikiki Beach. I grew up maybe a few miles east of this. And then lastly, all of my friends and close colleagues at UCSD, most of all Dr. Behar and Dr. Park, who is my MDS team at UCSD. And that's it for my talk. I'll let Lee take back over with the questions.
Great. Thank you so much, Dr. Tanaka, for the wonderful presentation. Does unclassified MDS fall into the same category as hypoplastic MDS?
Oh, sure. Yeah, great question. There's a tremendous amount of overlap, I'm sure. With some disorders, you basically cut off or rule out all the other things that are classically there. So, for example, ring sideroblasts or excess blasts or deletion 5q. And if none of those things are there, then you are stuck with that U or unclassifiable. And certainly hypoplastic patients can fit into there. What's weird is hypoplastic MDS is not its own WHO subtype. They can actually overlap with a lot of the different MDS subtypes. And that's an area of contention.
Thank you. This question comes from the father of a 20-year-old female that was diagnosed with severe aplastic anemia, was treated with ATG and Promacta, did not have a response, but 6 months later had a bone marrow biopsy that showed 7q, had an unrelated transplant in 2018, is doing well now. Seems like in your slide on MDS and severe aplastic anemia, since she had under 5% cellularity, no blast, but still no response to ATG and Promacta, what are your thoughts on a familial aspect here?
Oh, that's a fantastic question. Deletion 7q has been shown to emerge commonly after treatments such as the ATG plus Promacta. And there's actually some concern with does that clonal evolution or progression even get prompted by treatments? I'm glad that she got the transplant. That's her shot at the cure. For germline events or what's hereditary syndromes, that's an area that many people are proponents of for patients under age 40. That's just a rough cutoff. I would say that that's something that should be explored, just given the young age at which this occurred. But then nonetheless, she probably could still fit the typical severe aplastic anemia with the clonal emergence down the road. A genetic counselor could talk her through that. What are the risks of testing? and how to do that now that she's gone to transplant, but I don't think that's a bad idea.
Thank you. And can dysmegakaryopoiesis help distinguish between aplastic anemia versus MDS?
Well, that's a very good and advanced question. Actually, that's the one cell line that a lot of pathologists say is perhaps the best one to use for diagnosing hypoplastic MDS, where dysplastic megakaryocytes are more hallmarks of MDS rather than aplastic anemia. There's actually reports that aplastic anemia will have some dysplasia in the erythroid or the red cells, and so that can't be relied on, as well as the megakaryocytes.
Thank you. Can trisomy 8 occur in aplastic anemia?
Oh, sure. Yeah. So not as commonly. Trisomy 8 is very much a hallmark of hypoplastic MDS, and it's thought to be a common driver because it actually, there's a WT1 antigen, embryonic antigen from this type of chromosome abnormality that is one of those MDS-specific proteins that irritates the immune system and makes it too active. So it's very much thought to be more of an MDS type of lesion, but nonetheless, it can emerge in aplastic anemia.
Thank you. If your physician is trying to determine whether you are diagnosed with hypoplastic MDS versus severe aplastic anemia, does it impact using MDS therapies later if you undergo ATG as first treatment?
Oh, yeah. Fantastic question. Most times, no. I think I've had patients myself where we've done one hypomethylating agent therapy and then gone on to a classic immunosuppressive ATG regimen, and then vice versa. I would say if the patient is generally pretty much in good shape and can tolerate the treatments, then there should be no harm. There can be reactions to ATG, and often, patients are hospitalized for this regimen, but it should not affect the ability to get different treatments down the road.
Thank you. Is hypoplastic MDS considered low-risk MDS?
Oh, great question. Most often hypoplastic MDS patients are lower risk, but that being said, hypoplastic MDS is not in its own category, and so it's lumped into MDS, and so you still stage patients the same way, but majority of patients tend to be lower risk compared to the typical MDS patient.
Thank you. Is trisomy 12 a hypoplastic MDS indicator?
That's not as commonly seen. So yeah, I wouldn't say it's an indicator, but it could be used to supplement.
Thank you. What are your thoughts about a second allogeneic transplant in a young refractory severe aplastic anemia patient?
Yeah, it is being explored more. There are many reports of people that are still going for it, especially non-sibling donors. Our comfort level is increasing. For example, with cord blood, matched unrelated donors, or what's called haploidentical or half match from either a different sibling or from a generation below or above. The outcomes are going to be less probably across the board. But if refractory, then usually that's the only option to try to cure the patient.
Thank you. Can danazol be used to treat hypoplastic MDS?
Oh, great question. It has been used both in hypoplastic MDS and in aplastic anemia. Studies are not based on large patient numbers of patients, and the results do tend to be lower with agents like that. They're not quite as potent as something like ATG and cyclosporin, so the result rates tend to be much lower, less than 50%, but it has been a strategy I've seen tried.
Thank you. There's information that using eltrombopag or Promacta and MDS may not be recommended. What are your thoughts on the safety of MDS patients using Promacta?
Yeah, very hotly debated topic. The reason why we worry about perhaps spurring disease progression with this drug is Promacta is a TPO-mimetic thrombopoietin, and thrombopoietin is mostly going to spur platelet production. It actually can turn on your stem cell production. And so MDS is a stem cell disorder. And so that's why some people think you might prompt the MDS to get worse. That being said, if a patient is sort of through a lot of treatments, say they're elderly, say they don't have many options left, it is a treatment I'm not opposed to giving, but with these risks, very well understood with the patient.
Thank you. Are patients who are diagnosed with hypoplastic MDS at risk for developing AML?
Yeah, it's thought that the rates are much lower compared to hypercellular or more typical MDS. But nonetheless, it is still a risk. As shown in that study, there was still a substantial number of patients who went on to develop leukemia.
Thank you. And does hypoplastic MDS also occur potentially in pediatric patients?
Oh, great question. Yeah, there are, this came up earlier with hereditary bone marrow failure syndromes. There is growing research in this field and a lot of centers now that have dedicated germline or hereditary panels. And so if a patient is diagnosed with MDS at a young age, that's certainly something to be explored with a genetic counselor to understand what's perhaps down the road, what are other diseases that could occur.
Thank you so much, Dr. Tanaka, for taking the time to spend with us today and sharing your expertise with all of us. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you would like to submit another question, please feel free to do so by sending us in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice on bone marrow failure diseases. The AAMDS-IF Medical Advisory Board and team are here to help you and your family as we have done for the past 36 years. This concludes today's program. Thank you, Dr. Tanaka.
Thank you so much.